Good morning. This is Jim Taylor. I'm the host this morning. I'm CEO of Voices of Alzheimer's. We're kind of letting people dribble in for a few minutes. And I think we have a great program this morning. I'm really excited about it. I'm actually seated in a room that's very special to me. I'm in Orlando, Florida this morning at a terrific Alzheimer's clinical trial site. And it's called Charter Research. And last fall, they dedicated an entire new floor. They're growing so quickly and so many new participants in clinical trials. And they dedicated a beautiful conference room on this floor to my late wife, Jerry Taylor. And of course, I was tremendously honored and delighted about that. And they put up this plaque that I'll show you in Jerry's memory. So very special to us and to Voices of Alzheimer's, as Jerry was one of the founders. So that makes me feel good. And I've kind of thought that maybe once a year I'd come up here when I'm in Florida for the winter and do one of our webinars from here. So very grateful for that opportunity. So we have a terrific panel this morning on a very important topic. As I said, I'm Jim Taylor, the CEO of Voices of Alzheimer's, and our organization is relatively young. We're only 3 years old, founded in 2022. We've had a really, really exciting short life, but there's just so many tremendously exciting things happening in Alzheimer's and dementia research and in care and in treatment that we're going to talk about some of those this morning and why things have changed so much, even just in these 3 short years. But the mission of Voices of Alzheimer's, now, I've been told by my staff that I need to stay on script. There's too much pretending I was Johnny Carson last time. So I have to be dull, like is my normal personality, and stay on point here. So I'm going to do a better job today. But the mission of Voices of Alzheimer's is to advance equitable access to the latest treatment and care while ensuring that the patient voice is heard and represented at the table and respected. So our topic this morning is really something that's very, very important to Voices of Alzheimer's and should be important to all of us. Early detection of cognitive decline is a major focus for our organization. Late last year, we recorded an outstanding video called The Importance of Early Detection in Alzheimer's Disease. And our 2 physicians this morning who are on the panel were actually stars of that 4-minute video. The video was created in partnership with healthcare professionals, care partners, and families who have been affected by Alzheimer's to showcase personal stories and insights about how an earlier diagnosis can provide precious time for opportunity for treatment and care. We wanted to showcase the role of cognitive screening, annual wellness visits, and the importance of advocating for early testing with your healthcare provider. Actually, more people take care of their teeth and are responsible taking care of their teeth than we are for taking care of our brain. Teeth are important, but we also need to assume personal responsibility for taking care of our cognitive health. So with the advancements in the disease-modifying therapies and the blood markers, detecting Alzheimer's earlier can be make a life-changing difference. If you haven't seen the video, I believe it's showing on your screen, please check it out today. We want to continue to build on this important topic by discussing how early cognitive screening enables individuals to take control of their health, access treatment sooner, and contribute to research that advances new therapies. So 3 housekeeping points. We'll have questions and answers at the end, so about 15 minutes, but don't risk forgetting your question. Just put it in the chat as we go along. Also, if you have any technical problems, our hostess, Kim, is there. So if you have a problem, just put it in chat and Kim will help you. And we're being recorded this morning, so it's an opportunity for you to come back and go to our website, voicesofad.com, or tell your friends about it and access the recording. So our panel this morning I'm the least accomplished person in the room. Our patient is Dr. Mollie Geismer. Did I pronounce that right, Mollie?
Did.
She's sitting right here beside me. She is a participant in clinical trials here at Charter Research. Thank you. Two of our physicians this morning are actually in the video. They are on our medical advisory team for Voices of Alzheimer's, Dr. Deanna Willis, Dee, and Dr. Jared Brosch. Mollie, can you introduce yourself first?
Sure. I'm Mollie Geismer, and I also and I worked the majority of my clinical career in neuropsychiatric settings. So I've worked with a whole different, I've worked in a lot of hospitals, and I've worked with all different age groups. And as I went along in my training, I wanted to become more educated about different things. And I had pursued a master's degree in psychiatric nursing at the University of Maryland. And then I made the big leap to big commitment to PhD. I was selected and I have a PhD in social welfare policy. So I come with that clinical and professional background in neuropsych. I also come with a personal background because my father had Parkinson's disease, and from the time I was a little girl. So I've been, and he was getting cutting edge treatments. I mean, at the time, L-Dopa was a cutting edge treatment back in the 60s when he was getting it. And so I was exposed to things that I didn't quite understand at the time. And but that is something that I realized was a part of my attitude about things and about care. And that's how I happen to be here today.
Dr. Willis, would you introduce yourself, please?
Absolutely. I'm Deanna Willis. I'm a family doc, and I have expertise in quality improvement, practice transformation, and implementation science. That basically means that I like to improve the way that we deliver care in health systems, and in particular in primary care and transitions to specialty care, and have had the privilege of doing some work in how do we offer early detection to patients who come to primary care clinics, and how do we help get patients to the right care pathway based on their cognitive assessment and their other clinical testing and things like that. And where do these new testing and treatment options come into play for patients as they progress through that process? My father-in-law had Alzheimer's disease, and my mother-in-law devoted many years of her life caring for him in their home. And so this topic is near and dear to my heart as well. And I'm excited to talk with you today about these important topics.
So you have to tell us, are you in Costa Rica or?
I am right in my office in Indianapolis.
It's wonderful. Speaking of Indianapolis, Dr. Jared Brosch, would you introduce yourself?
Hi, everyone. I'm Jared Brosch. I'm a neurologist here at IU Health. I'm just found out right before the webinar that there's some construction happening around my office, so I'm a little concerned that there might be some noise. But I'm a neurologist who has participated in the development of drugs for the treatment of Alzheimer's disease over the past dozen years. And we have patients in Indiana who have been in all phases of the latest drugs that have been FDA approved recently. I've got somewhere between 150 and 200 patients on these new treatments right now. But I realize, like many others, that although I'm a neurologist, primary care is one of the most important places for people to get care, to be identified, and is going to be an absolute key for the future. And thankfully, I've been able to work with Dee and work with our university to to really focus on early detection. And that's one of the reasons I am so excited to be here today, so that I can share some of that work with you.
Jared, are you in the same building with Dee Dee? Are you all in the same building, Jared?
No, we're across downtown.
Downtown, okay.
Yes, yes, I'm sorry. I'm in the neuroscience building, so that's a little bit further away.
So let's get started with some discussion and questions. Mollie, can you start us out and tell us about your husband and early diagnosis there in that experience?
Yes. My husband, whose name is Dan, for several years, from about 2014 to about 2021, was working out of state. I live here in around Orlando, Florida. He was working out of state, and I didn't see him that much, except for long weekends, and holidays and such. And he ended that job and landed back at home in 2021. And there was, of course, sort of a period of getting to know him again and learning to live with him again. And I knew he needed some time to decompress from from where he had been and things that had happened. But I began to think something's different. And I couldn't, and I kept thinking, is it me? Is it him? And as time went on, I became more concerned. And having a background in neuro and in psych, I started thinking about what might be the possible changes, what could be going on, why is he different? He's an engineer, and he very much lives in his head and is very cerebral, but I found him sort of reacting differently, being a little quieter, just there were very subtle changes. And after a certain point, my friend said to me, you've been talking about this quite a bit. Have you had a neurologist evaluate him? I needed them to say that to me, I guess. And I took him to a neurologist, and she evaluated him. And then she said, well, you need to get some cognitive testing. And he got cognitive testing, and he did very well on most of it. He breezed through it. And but there were a couple of areas where he had problems. And she said, the neurologist said, I really think your best shot would be a clinical trial. And for me, that was great news, because I had been working in clinical trials, for cancer clinical trials, for about 10 years. So this was something that was very familiar to me. And I said, okay, well, yes, point us in the right direction, and, we'll go. And so that's how we ended up here at Charter. And very excited. And we came in, and Dan screened for several trials. And unfortunately, or fortunately, depending how you look at this, he flunked out of being eligible for the trials because he would score too high. He was functioning well enough. He had, a lot of pathways ways that he could compensate, and so he was getting kind of discouraged, and that he couldn't be in a clinical trial. And I encouraged him, but people at Charter were very encouraging and saying, we'll just keep trying. In the meantime, just for your information, I said, oh, is there anything are there any trials I could screen for? And they said, well, yes. And they said, did anybody in your family have Alzheimer's? Has anybody in your family had Alzheimer's? And I said, well, yes, my mother did. And so I went through the screening process for the AHEAD trial, which I am now in. And so I am speaking from a position of being someone who's dealing with someone who has mild cognitive impairment at the present time, and is in a clinical trial, and also myself being in a clinical trial, being a clinician, and people say, and you don't know what what's in the infusion that you're getting every 2 weeks? And I say, that is correct. I don't, but I have enough confidence in the process
That's beautiful.
to do this. And I certainly understand the apprehension that a lot of people bring to clinical trials. And when I was working in clinical trials, it was in cancer clinical trials,
Right.
and which are somewhat different, but they are governed by the same rules. And
So being in the AHEAD study
yeah,
means that you have the potential of developing symptoms.
yes.
Yes. And so is that because of the gene testing that you have been?
Yes.
Or have they identified plaque on your brain?
It is because of the gene testing.
Okay.
I have a single,
APOE.
I have a
4G.
single,
Okay.
I have a single APOE4.
What a couple.
gene. Huh?
What a couple. That's great. You've really great facilitation for this conversation. So really you didn't have a continual challenging sequence of physicians, because you came right away to the research lab, and it really got clarification of your situations pretty quickly.
Yes, I mean, with my husband, it was a little more difficult, just because I was the only one who was seeing him, and I
Right.
wanted to make the point that you can't do this by yourself. You
Right.
really have to have other people involved, your family, your friends, and as much for yourself as, so you let them know what you're going through.
Right up front. Yeah.
Right
Great.
up front,
Yeah.
and you'd be surprised at the help you can get, and the
Oh.
support, and the things that people will
That's
tell you.
So
and-
wonderful to
and-
hear.
And share.
Yeah, that's great. So Dr. Willis, we might not even been having this conversation 4 years ago. I mean, the world of Alzheimer's treatment and care has changed so dramatically. So why am I jumping up and down trying to get people to ask for a cognitive evaluation? People aren't aware that they should be doing this yet. And I'm trying to tell all my friends that we've got an opportunity here that we can't miss. So what is that opportunity, and what's changed?
Yeah, the exciting piece about all of this is that, when we identify someone early, just as an example in Mollie's story, there's opportunities, and there's opportunities for what people can do from a lifestyle standpoint, and things that they can do to keep their brain healthy and improve their brain function by the things they eat and do and on a day-to-day basis. And then also there's opportunity for new treatments for people that have certain criteria or conditions. And there's opportunities to participate in research and all of the wonderful things that can come from that, both at an individual and societal level. And so it's a multifactorial benefit that can occur when we identify someone early. But to a single person, it matters because doing those things and identifying early can help people make decisions, can help people have conversations with their family and their caregivers, and help empower them to feel like they're in charge of how they want things to happen as time goes on, and have a better understanding of what that might look like.
Jared, Dr. Brosch, what would you add to that?
Yeah, I second everything Dee Dee said, and I think, by having early knowledge and being able to institute measures in their home, sort of setting up a safety net, if you will, they're actually able to live independently longer, right? And that's a huge benefit to early detection, is how do I help set up my life so that I can have the support systems that I need to be independent. So I think that's a huge, huge factor. Of course, there are treatment implications too, and I don't want to get ahead, but I think all the things Dee Dee identified are critical.
So, Dee Dee, can you kind of walk us through? I mean, most seniors go to their physicians once a year to have their annual wellness visit. We may not call it that. It's our annual exam. But can you just tell us what's included? How does a cognitive screening fit into that appointment? And what can we do to make sure that we get the most out of those visits? Should we call ahead and tell the office that we want a cognitive evaluation, or will it just automatically happen like our blood pressure?
I think those are great questions. So one of the benefits in Medicare to someone who is a beneficiary of Medicare, someone who has Medicare, is that they can have a very specific visit called a Medicare annual wellness visit. And that visit, you do need to make sure that you're scheduled for a Medicare annual wellness visit, because it's a very specific type of visit. And that visit is designed to include a cognitive assessment as part of it. And so if you go to your primary care doctor and you ask for, when you schedule it, if you ask for a Medicare annual wellness visit, and you show up and you have this Medicare annual wellness visit, you should get a cognitive assessment as part of that. And if for any reason you don't, you certainly can ask for that, because that is considered part of that visit. And I think the most important thing that people and families can do to make sure they get out of the visit, when they go for that visit, or even if you go to your primary care doctor for some other reason, is let your primary care doctor know if you're experiencing some symptoms related to your cognitive health, and talk with them about it, and ask them if you can have a formal assessment of your brain health and how your memory is working. And those things, those structured assessments, can really make a difference in finding subtle changes that your doctor might not on their own identify, because they know you and you've seen them for a long time, potentially or hopefully. And they, in your visit with them and the conversations that you have, they probably will not be able to notice things without a more structured assessment if it's just mild symptoms you're having. And so that's where those formal assessments can be so important.
So when I went to my last annual physical, I asked my GP, my family doc, as you call yourself, could I get an evaluation? He said, well, I've already done one. I said, oh, how do you assess my cognitive skills? He said, well, I listened to how well you tell me what your medications are, and I remember how well you did that the prior year. And if I notice any change, then I might recommend that you go to talk to one of our neurologists. And I was pretty surprised by that, because, I didn't remember I always had to look at my list anyway of medications. And I said, so for these thousands of patients you see, you can remember back 12 months ago. Oh, yes, no problem. So what should I say? I mean, I don't like to push back, I'm not a physician. So how do I engage with that physician when he gives me a nonsensical answer like that?
No, I think that's a really great question. And, you like your physician and you trust your physician. That's why you've trusted them with your healthcare. And so it can be uncomfortable to ask questions of your physician. I think that in particular, when you've become informed about a particular part of your healthcare, it's appropriate to ask questions and to offer information that you've found and identified and inquire about that. And so responding by saying something to the effect of, that's good to know. I'm glad you do that. I've been reading a lot about this thing called early detection, and in older adults, and that doing a formal screening is really important each year in order to find subtle changes. Would it be possible for me to get a formal screening of my brain and my memory in the office today? Or at a future visit, and see what they say to that. So really be very specific about asking for that formal assessment.
So, it's so timely, that's so compact, and all we hear about is, oh, they've only got, 12 minutes or however minutes to look at head to toe. Can it happen at the same visit as the annual wellness Medicare physical, or is it a separate appointment I have to come back for?
Really good question. So the Medicare annual wellness visit is very prescriptive, and it can happen and it should happen at that visit if it's a Medicare annual wellness visit. If it's just an annual checkup and not specifically a Medicare annual wellness visit, your doctor might ask to have you come back for a separate visit to do the assessment. Or they might be able to do it that same day. Some of the assessments, they can give you a pencil and paper and have you do it independently, or an iPad and have you do it independently. And others, they or their staff have to actually sit down and ask you some questions. And so if they hadn't planned to do that, if it wasn't a Medicare annual wellness visit, they might ask you to come back.
And that's covered by insurance. That's not going to cost me anything out of pocket.
Every insurance is different, but it should be
That's an
it's
unfair
considered
question.
part of usual primary care. So however your insurance covers your
Okay.
usual primary care, it should be part of that.
So it's usually covered, right? Okay. So, Jared, this all sounds like it should be simple, but why is it not? What are the barriers today that keep people from getting cognitive evaluations or a baseline? Wouldn't it be good to just have one record of where I scored on cognitive evaluation in my electronic record?
Yeah, it's a great question. I know Dee Dee has described some of those difficulties. You've talked about the time management difficulties, and when I talk to primary care providers outside of IU, one of the things we talk about is when someone has a complaint, trying to break things up into bite-sized pieces. Maybe that means you go back for an additional visit and have an assessment done. Like Dee Dee said, there may be digital ways to do that. Maybe you do an assessment with a nurse, which is something we're modeling in our own system, where a separate nurse is able to provide a standard cognitive assessment that we can refer to. A comment in the chat from Sam was really good too. When we have a really educated person who's doing all the right things, but they still have a complaint, that's a person we really want to dig deeper with, right? And that may be more than just a cursory, well, you did well with your medications, right? And that might be something like a 10-minute assessment, but it could also be something longer, like an evaluation with a neuropsychologist. One of those barriers is that there's not so many neuropsychologists, and there's not that many neurologists and geriatricians and geropsychiatrists who provide these services. So making people aware, helping raise awareness like this, helping, as Dee Dee and I are with literature and trying to educate primary care providers to raise awareness for brain health, we're hoping that more of these systems and easier access to testing gets in place.
Mollie?
I just want to add one thing to what Dee Dee and Jared have said from kind of a clinic perspective and experience, is that when you are going for that evaluation with your doctor, please have somebody else with you, because it may be that you're apprehensive about talking about any problems you might have, or you're not aware of them. And it's always good to have somebody else there saying, well, that's true, but I have noticed that there's been whatever. And so that is another person is an important ally to have with you at an evaluation appointment like that.
That's a great point, Mollie. So
I love
when,
that point too. Bring your favorite or least favorite child with you to your appointment. You're guaranteed to get some feedback.
um, Molly, are there particular problems and challenges in getting a diagnosis and getting on a path? It sounds like you are both on a pretty good path right now.
Right,
What,
well,
what challenges did you see getting started or along the way?
well, time was one of them, was once we sort of on the path saying, okay, well, I'm ready to start the trial. And it was, for me, it was about 6 months until from when I first screened for it and signed consent to when I started. And so that's one thing. I mean, another thing is becoming familiar with kind of what the routine is going to be for this study. And making sure that you're clear about, as clear as you can be about what your experience is going to be. Is it, are you going to be receiving infusions where you have to sit somewhere for a few, an hour or so? Are you going to be getting injections? Are you going to be getting pills? There's some very practical aspects to what's involved and how often you have to be there. And it's, it's important also, I think, and the charter made this really easy for Dan and me, that you feel comfortable at the place that you are receiving treatment and the research group that you are working with.
Great. So Molly and her husband are among my favorite people because everybody's a favorite person of mine when they're participating in clinical trials. We have a tremendous need for people to be in trials. Less than 1% of people living with Alzheimer's participate in clinical trials. That's a remarkably low number. But also what Molly's talking about, so I would encourage everybody in the audience to consider, that it's not right for everybody, but is tremendous progress can be made if we could increase the number of people participating in trials. But also now Molly is talking about the time required to be in a trial. There is a parallel now in general treatment of people living with Alzheimer's, in that we have 2 FDA-approved disease-modifying therapies, but that time requirement and that thought of scheduling comes into play as well. And I'm going to turn to Dee Dee and let Dee Dee kind of address that. What are the tremendous treatment and diagnostic progress that's been made? Why is it that we're so excited and encouraging people to be screened and get identified?
Again, a really great question and really timely, because there are a lot of new testing and treatment options, and some of the exciting new testing options that we've been able to look at and try out in primary care include things like iPad-based cognitive assessment. So there have been some questions in the chat about like reliability of these paper and pencil tests and who gives them and how they're given. And some of these new screening tests are, on an iPad, or some of the other tests, for example, run behind the scenes in the electronic medical record to identify risk factors. And so the better we can get at creating tools that are harder to break, and can more reliably be applied across lots of people and scaled to look across lots of people, and help identify and understand risk, the more we'll be able to get systems in place that help connect people at risk to the right care pathways. So those are exciting things. And then another exciting development is the advent of blood-based biomarkers. And part of why that's so exciting is that blood-based biomarkers have the potential to be really important tools in primary care as well. and can help us hopefully in the future begin to stratify people at risk to better understand who might be a good candidate to see a neurologist for treatment, for example. I know Dr. Brosch has a lot to say on this topic because he's been part of the teams that have been investigating and doing research on all these new treatments. So I'm going to let him talk to this question too.
Yeah, I'll follow up what Dee Dee said. Dee Dee is the senior author on a paper that was just published within the past week or two that is looking at digital cognitive assessments in primary care and their reliability and some of the initial impressions. And I think we're going to see many more of these tools become integrated into electronic medical record systems. They take away a lot of the variability, and hopefully they're going to help us be much more effective at getting that first sort of screen at whether or not a person has some changes that we need to dig deeper into. And hopefully we get that infrastructure where we can really start to dig deeper. Those blood-based biomarkers Dee Dee talked about are things we're really interested in too, because they might be able to help us say, with some degree of certainty, these cognitive changes are due to Alzheimer's disease, right? And that is one of the key parts of the pathway that gets us onto newer therapies. There's a lot of therapies that are available now, and more that are on the way that we're really, really excited about.
Oh gosh, I have to keep paying attention to the script here. You know, I still meet people who believe that the only way you can tell whether or not somebody has Alzheimer's is an autopsy. So Dee Dee, are you trying to tell me that just a blood draw can tell me whether or not I have Alzheimer's?
So I'm old enough that I was taught in medical school that that was a true statement. That was what I was taught when I went to medical school. And science changes. That's such the exciting thing about all the medical research that's going on and all this amazing work that's going on in Alzheimer's disease and related dementias. And science has evolved past that. And that's why this is so important, because it has moved from where it was when I was in medical school. It's moved a long ways from there, but we're on the cusp of really important breakthroughs. And now is the time to become informed, just like everyone on this call is doing.
So surely that blood draw isn't covered by insurance, Medicare, is it?
So
Trick.
currently no. Currently no. In
No,
fact,
I'm sorry, Jared, it was a trick question. I actually, it
Okay,
had,
you're gonna answer. You're gonna
yeah,
answer?
as of January 1st. It's so recent. Medicare now covers. It's not the same price across the country. Different regions have different prices there, but it is actually it's only a few $100s. I mean, so many people can afford to pay it out of pocket. Sorry, Jared, didn't mean to trick you. But we finally got from an autopsy to a PET scan. That cost $5,000 to $10,000, but that wasn't covered by Medicare until last year. For 15 years, we couldn't get the definitive diagnostic evaluation. Now it's as simple as a blood draw, and it can be done at a clinic or a doctor's office. So, and these new screenings on a digital evaluation, Dee Dee, are you comfortable that they're as accurate as the one-to-one testing that we used to have with pencil and paper? Or Jared, who's the better expert here? I guess
Jared's always the better expert. I'm just going to say that flat out. But I will say that, I think so part of my job is teaching new
right.
doctors. And, I think that the process of learning how to understand, when you look at a clock that someone's drawn and understand how to interpret that, you have to learn that, and you have to remember it, and you have to not let your own thoughts and conscious and subconscious thoughts come into how you interpret it. And the beautiful thing about like these iPad-based tests and things like that is that that those things don't take into account
No human factor
and
error.
they become more consistent in how they deliver results. It's not to say that they're, you can read all sorts of articles in lots of different news literature about, bias and how that gets introduced into algorithms and computers and things like that. So it's not that there's not that stuff there, but it's just that they're incredibly reliable. They reproduce every single time a very consistent result.
So this is artificial intelligence helping us already.
Yeah, absolutely.
So
Yeah.
let's,
Can
yeah,
I follow that up? I'll follow that up just really quick, Jim. Yeah, when we first started using some of these digital assessments, some of our primary care doctors would come back and say, I don't agree with this. Right?
yeah,
I don't but when we go and dig into the data, we're like, well, that is an abnormal clock. Yeah. And on part of our team, we have a neuropsychologist who has been working with the individuals who make these digital cognitive assessments, and those companies that make the digital cognitive assessments have done a really rigorous job of comparing them to more traditional pencil and paper types of studies that are implemented in the right way by trained individuals, and they are incredibly reliable. And
wow.
we have to keep in mind that these tests are meant to detect people at the earliest possible point. So there are going to be some, false positives, so to speak, but we're trying to capture as many people as possible and then sort out who are the false positives. So those are some of the factors. And we have to keep in mind, how is this person's hearing? Can they hear the iPad? And are they in a noisy environment? And can they see everything okay? And so there's a lot of other factors that we all have to keep in mind when we use them.
So let's say I go for my annual wellness Medicare visit, clarify. I have one of these great new artificial intelligence digital evaluations. It shows some concern. It's in the gray area. So then I can go and get a simple blood test. And this blood test reveals whether or not I have a protein on my brain, amyloid or tau, that indicates whether I most likely either do have some symptoms or that I may have symptoms approaching, that I do already have the protein. So for decades, Jared, that's nice information, but I don't really know if I want to know or not. A lot of people tell me, I don't want to know. Well, why do we want to know today? Why is it different?
Yeah, great question. I'll mention there's one caveat. Of course, we don't have an FDA approval yet for the blood tests, so that is something that is that we're waiting for. And
It's
so
expected soon.
as physicians, I have to add that caveat that we're talking about something that's not quite FDA approved yet. But the idea that we can detect, and so there's been this huge push across the world to, instead of just say, oh, you've got some cognitive changes or even mild cognitive impairment, but to qualify that further and to say, you have mild cognitive impairment due to Alzheimer's disease, right? This is one of the most important things we can do, right? When we talk about cognitive impairment and dementia, that just talks about a description about someone's cognitive functioning and their day-to-day abilities, but we want to know what the cause is, and that's really, really important. Gone are the days where we say people are senile or they had hardening of the arteries. We want to know, because the newest treatments, the ones that can remove plaques, they work the best in people who are captured at the earliest possible point. And Mollie is in an absolutely critical clinical trial where we're looking at people
Yeah.
who
Yeah.
are receiving these treatments before they have ever suffered their first symptom, right? So this is something that we think is sort of the holy grail for the future. And it might be that someday in the not too distant future that we come back to a webinar like this and you hear Dee Dee say, well, we do, mammograms, PSAs, colonoscopies, and we check people for an Alzheimer's blood test without even asking them about a symptom. We are not there yet, right? Right now, we're talking about early detection of someone's cognitive changes at the earliest possible point. But, we know these drugs can really help the earlier and earlier that people are. So far, that's what we've learned.
I would just also add to that, I think when someone's having some changes in their cognition, part of the primary care doctor's job and part of the hard part about what primary care doctors have to do is to look for all the other possible things that can affect cognition, even if someone has underlying plaques and amyloid and tau and Alzheimer's changes. And so, depression, anxiety, thyroid disease, sleep apnea, alcohol intake, certain medications and some of the side effects of those medications. It just goes on and on, this big list of things about things that can make your brain just not function as well as it can, potentially, if those things were not a factor. And so your primary care doctor, part of the primary care doctor's job in all of this is to try and find those things and then try and help reduce the effect of those things on your brain, even if you end up having signs that may be early Alzheimer's disease and need to move on into Alzheimer's specific therapies.
So it might be that you're having cognitive problems, but they might be reversible.
There are some people who have cognitive changes who have these other addressable or reversible causes. And when we get those things in better shape, their symptoms and their findings go back to what they were before.
And your family
They won't
doc,
have more problems in the future necessarily, but their cognition improves because of those things, and in some cases goes back to their normal state of cognition.
and your family doc is the right point to address all those issues.
Absolutely.
Yeah,
Mollie?
and even if you have Alzheimer's disease, addressing the issues that Dee Dee said can help slow progression.
Mollie.
Yes, I just wanted to add to what Dee Dee and Jared had said in terms of talking about, well, yes, this stuff isn't, these tests aren't all routine yet. They're not covered. They're being tested. Well, that is one of the great reasons to participate in a clinical trial, because if you are in a clinical trial, you will have access to, depending on the clinical trial,
Good
for
point.
Alzheimer's or other neurological conditions, you will have access to a lot of those tests. And whether they are scans or blood tests or computer tests, and it's a wonderful way to participate and to get information that you need. And one of a number of the people that I worked with previously who were in clinical trials said to me, because they were saying they were very quick to agree, and they said, yes, I want to do this. And I said, well, that was, you didn't have to think about that too long. And they said, well, yes, somebody did this for me. For every single drug that you take, that anybody takes, somebody else has been part of a clinical trial and gone through that.
Right. This is a great discussion. I just am so grateful for you three joining us this morning. The time is flying by. We better jump to some more questions. I think you all have picked them up and answered some, but Kim, are you available to share any online questions?
Yes, Jared and Dee Dee answered many in the chat. So there aren't any additional, just mainly comments here. But if anyone else has additional questions, please feel free to post.
Yeah, and there's one from Sam at the bottom there, and I can address that.
Oh, thanks, Jared.
Yeah, no problem. Sam mentions that there may be some disadvantages to clinical trials and how that might prevent a person from having access to a drug. And I guess I would say that this is not a huge concern in my opinion. It really depends on the situation. Many clinical trials, they have a washout period, and the newer drugs that we have, as long as a person has sort of washed out from whatever previous treatment they were on, they absolutely have access to the newest treatments. I don't think that should be a discouraging factor for most individuals. And also there are clinical trials that people can be in that are observational, where they're just contributing data that might help, where they're also getting feedback. So as an example, there are some longitudinal studies. We have them all across the United States where you can get an amyloid PET scan and an MRI and yearly neuropsychological tests, and you're just contributing to our overall knowledge without having exposure to a drug. So lots of great options in that sense.
I spoke yesterday with a friend who's considering joining a clinical trial that is the treatment removes tau, and this participant is already on Leqembi. So that this trial will have a section of patients, of participants who's already receiving the amyloid removing drug on their own, and also will be receiving tau removing experimental treatment. I mean, this is such a step forward. This is why we need more people participating in trials. This is kind of a side benefit of this conversation, which really isn't so much about trials, but just we're really talking about the incredible advances that we've made. And, where Dee Dee and Jared, and actually Mollie too, in trials, which has been part of her profession, are doing so much of this leading edge work that we're so grateful for. As we come down to our last 5-10 minutes here, Dee Dee, do you have final thoughts you've shared so much, and thank you for sharing so openly and honestly about your experience. I know from personal experience that it takes some courage to be able to say in front of a lot of people what it's been like to live with this disease.
Yes, I guess my take-home comments would be, both from a professional and a personal standpoint, are don't try to figure this out all by yourself. Get support. It's not a sign of weakness to know when you need some help. It's a sign of being very smart and taking care of yourself. And don't, it's important to have other people involved. So, because the tendency can be to just sort of minimize when you're just thinking about yourself and what the problem might be. And the other thing I wanted to say about clinical trials is one of the misconceptions people have about them is that it's sort of like signing a mortgage or a loan or something, and that you cannot get out of it. And once you sign on that dotted line, you are committed to being in that clinical trial. And that is not the case with clinical trials. That if at some point you think that you don't want to participate anymore, that is always an option. That's it.
Thanks, Dee Dee. Mollie, sorry. Dee Dee, would you like to leave us with thoughts?
I would say that, the health systems around the world, and the US in particular, were built and designed based on processes from when I was in medical school, when Alzheimer's was diagnosed at autopsy. And there have been changes in health systems and processes of care. But at the end of the day, the research and the changes in diagnosis and treatment have progressed much, much faster than changes in healthcare systems. And so as a patient or a caregiver or a friend or family member of someone who needs to interact with the health system around this topic, it's very easy to get frustrated. And doing what you're doing by attending webinars like this, thinking and learning about how to advocate with your healthcare provider, with your health system, thinking and learning about how to advocate with all the advocacy groups that are doing amazing work and trying to change policies and structures. all incredibly important as we all move through this journey together.
Thank you for that comment about how research is moving so quickly and our healthcare systems maybe not so. And the frustration that, gosh, you all know every day, and we as patients encounter, but not as regularly as you, and how important that is to try to remain patient, being patients. Dr. Brosch.
Yeah, I second everything Dee Dee said. Raising awareness, advocacy, organizations like VOA, these are critical to help change what's out there. And every person here can really help with the supply and demand portion of what our healthcare system currently is, right? So if we all go into our primary care doctors and we demand in a very nice way, some additional cognitive assessments, then eventually those primary care doctors in the system are going to see that there is a demand for services and they have to do a better job at delivering those services. So, I think everybody has a role here and they can help us evolve the system and make it better.
So you three are just terrific partners in this. So happy to have Mollie here in Orlando, and there are two Indianapolis centers of excellence in our physicians. Thank you, Jared and Dee Dee and Mollie, very much. Now my script says, thank you for joining us for this insightful discussion on early detection. We hope that these insights will empower you to take a proactive step in recognizing and addressing cognitive health concerns, while also deepening your understanding of our community and at VOA, the advocacy efforts to educate primary care physicians as well as patients. Early detection is key in assessing new treatments, improving care, and supporting patients and families in navigating this journey through the healthcare system that Dee Dee just referred to. We encourage you to share what you've learned today and with your network, and to continue to stay updated with our advocacy efforts and our initiatives by reading our newsletters, listening to our podcasts, and following us on Facebook, Instagram, and X. A reminder that the webinar today will be on our website at voicesofad.com. Special thanks to Mollie, Dee Dee, and Jared. And thanks for being part of our audience. It's really wonderful to have you. If you're not already a member of VOA, we really would like to have you sign up, because we're having exciting webinars like this frequently, and we're really raising the voice of the patient, we think, to a level what's not been heard before. Thank you very much. Good day.